My name is Peter Ellis. I am a clinical professor of medicine at the University of Pittsburgh School of Medicine and a practicing hematologist-oncologist. For 25 years, I have practiced in hematology and oncology, and for 23 of those years, I've been privileged to teach the family practice residents at UPMC St. Margaret. I've been asked to give a talk on the evaluation and treatment of anemia as well as thrombocytopenia, and we'll do our best to get through that in this 1-hour time slot. We'll start with anemia. The first part of this talk will be given in 3 sections. One is we'll talk about the physiology of erythropoietin, the driving force behind red blood cell production. We'll talk about the physiology of that red blood cell production, otherwise known as erythropoiesis. And then we'll outline a methodology to evaluate anemia in the clinical practice that narrows down what is typically a very broad differential diagnosis into a workable few. So what is erythropoietin? What is a hormone? It's manufactured in the kidney near the juxtaglomerular area. It is manufactured in a hypoxic state, meaning that what the kidney senses when it needs to make erythropoietin is hypoxia. The kidney does not sense blood pressure. The kidney does not sense the number of red blood cells. Rather, it measures the oxygen content in the blood. Thus, when the oxygen content is low, the kidney makes more erythropoietin. And in those cases where the oxygen content is low because of a pathologic state, such as living at 25,000 feet in the Andes, or such as smoking, or such as a right-to-left heart shunt, we often see a physiologic polycythemia related to that high erythropoietin level. Erythropoietin transcription can go up 50-fold in the case of hypoxia, allowing us to rapidly increase the production of red blood cells. This is a model of what that oxygen sensor looks like and how in a normal oxygen state there is very little transcription of erythropoietin, but in a hypoxic state there was rapid transcription of erythropoietin. This slide shows the the rapid rise in erythropoietin that is associated with developing anemia. As you can see, this is a linear scale on a this is a linear line on a logarithmic scale, indicating that there's a rapid and significant rise in erythropoietin with a drop in hematocrit. So erythropoietin not only is produced in the kidney, but it is also produced in the fetal liver. It is the potent regulator of red blood cell production. It is available synthetically in the form of Procrit or Aranesp. It has a half-life of 5 hours. Not only does it stimulate red cell production, but it also protects from hypoxic neuronal brain injury. It does mediate vasoconstricted hypertension as a side effect. It suppresses hepcidin, which therefore allows for increased iron absorption. And there is some data that it may improve memory. So at steady state, we make 10 to the 10th new red blood cells per hour. That red blood cell production starts with an erythroid burst-forming unit, which rapidly, under the stimulation of erythropoietin and other cytokines, migrates and forms colony-forming units, which then form proerythroblasts, the earliest precursor that's visible in the bone marrow. Each proerythroblast will continue to mature and divide into numerous erythroblasts, and then polychromic erythroblasts, and then orthochromic normoblasts, which means the cells look more like red cells. There will be extrusion of the nucleus, and then we will have what we call a reticulocyte. This is a brand new, freshly born red blood cell. That reticulocyte will spend some time within the bone marrow, and then will diapedese outside of the bone marrow into the peripheral blood and eventually mature into a red blood cell. The process from a burst-forming unit all the way to a red blood cell takes only 14 days, and from the colony-forming unit, only 7 days. From the proerythroblastic state, only 5 days. This is a diagram of the size of those cells and what they look like under the microscope on a normal bone marrow. So what are the characteristics of a red blood cell? Well, they typically last 120 days, or 4 months in the blood. They contain hemoglobin. This is vital to carry oxygen to the tissues. We all remember from our biochemistry that if we metabolize C6H12O6 under anaerobic conditions, we get 2 ATP. However, if we take that same molecule of glucose and metabolize it under aerobic conditions, we get 36 molecules of ATP. Therefore, delivery of oxygen is key to the production of ATP and to life as we know it. The unfortunate truth is hemoglobin is a toxic molecule. It causes oxidation. Therefore, the body packages it within a red blood cell membrane to protect the tissues from hemoglobin while it's doing its vital job of delivering oxygen. So what about that red cell? Well, it's uniquely designed to carry oxygen. It's 7 to 8 microns in size. Interestingly, the capillaries are only 5 microns in size. That allows the red cells to bunch together closely within the capillaries and get a high density of red cells so that there's maximum distribution of oxygen into the tissues. Interestingly, the spleen, which is an immune organ but also a conditioning organ, has a pulp called the cords of Billrath. That pulp is only 3 microns in size, and as the red cells circulate, they need to get through that pulp in order to continue to circulate. This takes aging or defective red cells out of the circulation and only allows those that are highly distensible to continue to circulate and deliver oxygen. Why are they highly distensible? Red blood cells have high membrane to cytoplasmic ratio. They have the absence of a nucleus, so there's no hard ball and chain to pull through the capillaries. And they're all negatively charged, which allows them to repel each other and actually allows to grease the skid, so to speak, to allow the red cells to slide by each other. This mechanism, hemoglobin within a red cell that's highly distensible, allows for efficient delivery of oxygen to the tissues, placing oxygen where it's needed to produce ATP. This photomicrograph shows a picture of a red cell extruding out of an injured capillary to give you a sense of the size. So, what is anemia? Well, we define anemia as a hemoglobin less than 14 in a male and less than 12 in a female. What's the difference between the two? The difference is testosterone. Testosterone is a hematemic. Men have it, women don't, and that's why a man's hemoglobin is typically 2 grams higher than a woman's. There is some variation in hemoglobin based on race. African Americans typically run a half to 1 gram lower than Caucasians. In order to differentiate the broad differential diagnosis of anemia, we take advantage of the kinetics of anemia. There are essentially 2 reasons a patient can be anemic. Either they're not making enough red blood cells, a decreased production of red blood cells causing their anemia, or conversely, the bone marrow is working fine and making plenty of red cells, but those red cells are not lasting long enough in the peripheral blood, this being an anemia of increased destruction, otherwise known as hemolysis. For this reason, because there are 2 broad categories of the causes of anemia, and because we want to get rid of one of those broad categories when we're trying to consider what our differential diagnosis is, the first test we do is a reticulocyte count to differentiate between these 2 broad categories. What is a reticulocyte? A reticulocyte is an immature red blood cell. It's that red blood cell right after the nucleus is excluded. How is it identified? It's identified by doing a reticulum stain on a peripheral blood smear, and that stain stains for the RNA that still remains within the cytoplasm. The RNA, as you know, is a template for the production of proteins. That RNA will eventually break down once the nucleus has been extruded. It takes roughly 3 to 4 days for that RNA to break down. Hence, a reticulocyte is recognizable for the first 3 to 4 days of its life by having stainable RNA. This is a picture of a reticulocyte on a reticulin stain. They're quite obvious, as you can see in this picture, and also slightly bigger than the remaining red blood cells. Now, if we assume that an average red blood cell lasts 120 days, then one would reasonably expect that we have to replace a little bit less than 1% of those red blood cells every day, roughly 0.8%. However, the schistocytes that come out of the bone marrow each day often last more than 1 day in the peripheral blood. They often last 2 days before they lose all of their RNA. And therefore, when we do a reticulum stain, we are counting all the reticulocytes that came out of the bone marrow today, as well as the reticulocytes that came out of the bone marrow yesterday. So if we were replacing roughly 0.8% a day, then a normal reticulocyte count should be 2 times 0.8 for yesterday's and today's reticulocytes, or 1.6%. This reticulocyte count can be significantly enhanced by the presence of erythropoietin. Erythropoietin not only recruits more blood cells to go down the red cell production line, but also stimulates the release of those reticulocytes from the bone marrow into the peripheral blood earlier than they typically would be released. This is a diagram that tells us how long reticulocytes typically stay in the bone marrow versus in the peripheral blood. In a normal setting of a low erythropoietin state with a normal hematocrit of 45, 3 to 3.5 days the reticulocyte spends in the bone marrow, only 1 day in the peripheral blood before it loses its RNA. But as the hematocrit goes down, and conversely the erythropoietin level goes up, those reticulocytes leave the bone marrow earlier and earlier and spend more of their time maturing in the peripheral blood. When the hemoglobin is below 30, we typically think of the time spent in the peripheral blood as doubling, therefore requiring a correction of the reticulocyte count in anemia. How do we correct? Well, the first thing we do is if we're doing a peripheral blood film looking at reticulocytes, we count the number of reticulocytes per 400 cells, but then we divide that by the observed hemoglobin over a normal hemoglobin, which would be 15. Why do we do that? Because we're counting a percentage of a smaller number of cells. We need to correct for the fact that a normal hemoglobin would be 15. Secondarily, we correct for the fact that each reticulocyte is spending more days in the peripheral blood. So when we count our number of reticulocytes, we're not just counting today's and yesterday's. We may be counting 3 or 4 days worth of red blood cell production, and we need to correct for that. A simple approach would be to divide the reticulocyte count by 2 if the hemoglobin is less than 10. This is an example. If a patient has a hemoglobin of 8 and the retic count is 4%, we would then times that by 8 over 15 and get 2.1%. But then because the hemoglobin is less than 10, we would divide it by 2, and we would have a reticulocyte count of 1%. This 1% reticulocyte count is inappropriately low for a hemoglobin of 8, and therefore this is an anemia of decreased production, not an anemia of increased destruction. So once we have developed or understand the kinetic basis of the anemia, now we can begin to develop our differential diagnosis. We know from our reticulocyte count whether this is an anemia of decreased production or an anemia of shortened survival or increased destruction. This graph shows you how the reticulocyte count will drive you to one side of the differential diagnosis or the other. Conversely, the reticulocyte count can narrow the differential diagnosis with one test by roughly 50%. We will now discuss those anemias of shortened survival or increased destruction, otherwise known as hemolytic anemias. As you can see from this graph, there are very few causes of this anemia, and they're easily discernible by the clinician. We're going to start with intrinsic defects of the red cell that can lead to shortened survival. What factors are intrinsic to the red cell that can lead to a shortened survival? Well, each red cell has a membrane. Membranes can be dysfunctional in the form of membranopathies. Every red cell has hemoglobin. Hemoglobins can be dysfunctional in the form of hemoglobinopathies. And every red cell has enzymes, and those enzymes can be deficient in the case of enzymopathies. We also can have destruction of red cells by factors extrinsic to the red cell, such as autoimmune hemolysis, mechanical hemolysis, or infectious etiologies. And finally, there are one-off causes of shortened red blood cell survival, such as paroxysmal cold hemoglobinuria and paroxysmal nocturnal hemoglobinuria. So let's start with those defects intrinsic to the red cell. The membranopathy. What is the most common membranopathy? That's hereditary spherocytosis. It's an ankyrin defect causing low membrane to cytoplasmic ratio. What does that mean? It means the cell is not as deformable because it's more spherocytic than it is a biconcave disc. This is an inherited defect in the autosomal dominant manner, and this decrease in deformability of the red blood cell causes the red blood cells to pile up and get stacked into the cords of Billroth in the spleen. This causes splenic hypertrophy, and it causes shortened red blood cell survival, with an increase in breakdown of the cells in the spleen, leading to a hyperbilirubinemia and splenomegaly. On a peripheral blood film, spherocytes can be seen, and the diagnosis can be confirmed with an osmotic fragility test. This is a graph of an osmotic fragility curve. The curve on the right is a normal curve. As you can see, as my red blood cell is subjected to increasing hypotonicity of fluids, the red cells really do not begin to rupture until we get down to near half normal saline. Then the red cells rupture relatively quickly. This is because there's a lot of extra membrane for the cytoplasm, and fluids can rush into the red cell and dilute the cytoplasmic elements of the red cell to prevent rupture. However, the curve on the left is that of spherocytes. Because the red cell's a sphere, it does not have a lot of room to take on extra fluid, and the rupture or hemolysis of the red cells occurs relatively quickly as we expose it to increasingly hypotonic fluids. This is called a shift to the left and is diagnostic of hereditary spherocytosis. What else is intrinsic to the red cell that can go wrong? Hemoglobins. Hemoglobinopathies cause shortened survival, usually because of hemoglobin-induced conformational changes in the red blood cell membrane. This causes splenic sequestration, much like it does in hereditary spherocytosis. The most common hemoglobinopathy in the United States is sickle cell disease. Typically, however, hemoglobinopathies are named for the city in which they are described: hemoglobin Paris, hemoglobin Prague. They are diagnosed with a hemoglobin electrophoresis, as these abnormal hemoglobins will migrate to a different point on the hemoglobin curve than hemoglobin A1, A2, and F. Finally, intrinsic to the red cell, we can have enzymopathies. Enzymopathies meaning defects in the production of a necessary enzyme. The most common that we see is G6PD deficiency. This is an X-linked disorder where the X chromosome has a handicapped G6PD gene that cannot produce the same amount of G6PD as the normal gene. When the red blood cell is born from the bone marrow, it may have only 50% as much G6PD as it should. Unlike the other cells in the body, it cannot go back to the nucleus and turn on more G6PD when it runs out because it has lost its nucleus. Therefore, once the red cell begins to age in the peripheral blood and what little G6PD it had begin to get used up, it is susceptible to oxidant stress. Once it sees oxidant stress, it unfortunately ruptures, and we have the hemolysis associated with G6PD deficiency. We see the same thing in multiple other enzymopathies, pyruvate kinase deficiency, and then a host of others that have been identified in individual families. We lump these together and call them the congenital, non-spherocytic hemolytic anemias. So that's what's intrinsic to the red cell that can go bad: the membrane, the hemoglobin, and the enzymes. Well, what can shorten the red blood cell survival extrinsic to the red blood cell? Most commonly, that would be an autoimmune hemolysis. Autoimmune hemolysis meaning our own immune system is destroying the red cells prematurely. That destruction can be mediated by IgG, which is also called a warm antibody. The red blood cells are coated with IgG and then destroyed in the spleen. Or it can occur with IgM antibodies, called a cold antibody. The IgM antibodies often cause intravascular hemolysis, which is much more detrimental to the patient because of the free hemoglobin then circulating in the peripheral blood. The diagnosis is made with a direct antiglobulin test, otherwise known as a direct Coombs test. The initial Coombs test is done with polysera, which looks for either IgG on the surface of the red cells, or it looks for C3 on the surface of the red cells. C3 because typically the IgM has fallen off and only the complement that it activated is left on the surface of the cell. Treatment of these autoimmune hemolytic anemias is dependent upon whether it's a warm or a cold-mediated autoimmune disease. Other than autoimmune disease, what else extrinsic to the red cell causes red cell destruction? Well, there is mechanical destruction. We lump the mechanically destructive diseases into microangiopathic hemolytic anemias. These are characterized by shear forces that destroy the red cells and break them apart. These are best evidenced by the presence of schistocytes in the peripheral blood. These types of anemia do lead to an intravascular hemolysis. They lead to free hemoglobin in the blood and sometimes free hemoglobin in the urine. At the very least, that hemoglobin that gets into the kidney is broken down. Blood or iron is deposited in the kidney, and then that iron can be seen in a morning urine if one does a Prussian blue stain. We typically see a low haptoglobin because haptoglobin scavenges that free hemoglobin that's in the peripheral blood. They are characterized by the presence of schistocytes and high LDH. And the common causes of microangiopathic anemia include DIC, TTP, March hemoglobinuria, valvular hemoglobin breakdown, and vasculitis. This is a picture of a schistocyte. You can see the normal red blood cell here, and you can see the fragments of red blood cell in other areas. These are always pathologic. Another source of external destruction of the red cells would be infectious. We don't see much malaria in the United States, but we do see it coming from abroad. It's a mosquito-borne disease that causes intracytoplasmic parasites. These are found on peripheral blood preps. Babesiosis, more endemic to the United States, is tick-borne and again is diagnosed with a blood film. Finally, there are one-off causes of hemolytic anemias. Paroxysmal nocturnal hemoglobinuria is a membrane disorder in which there is a clone of the stem cell that's missing the proteoglycan leak that protects those red cells from complement destruction. We see excessive complement destruction of red cells intravascularly in PNH. We also see hypercoagulability in association with that as well. And the final cause is paroxysmal cold hemoglobinuria. This is an autoimmune destruction of red blood cells, but unlike most autoimmune diseases in which IgG is warm and IgM is cold, in this case, the IgG is cold. It is a devastating form of hemolytic anemia. It is associated with tertiary syphilis and thankfully quite rare now in the United States. So, that is our anemia of shortened survival. We have a CBC. We did a retic count. The retic count is high, telling us that the bone marrow is functioning normally, and so therefore we look for reasons of shortened red blood cell survival. We look for intrinsic defects, immune defects with a Coombs test, mechanical defects by looking for schistocytes, infectious defects by looking at a peripheral blood film, and then all else being negative, we look for the one-offs. Well, what about the other side of the spectrum? What about when the retic count is low? This is by far the more common scenario. Over 80% of anemias will have a low retic count, meaning that they have a decreased production out of the bone marrow. How do we differentiate those? We differentiate those using the morphologic characteristics of whether the cells are microcytic, whether they're normalcytic, or whether they're macrocytic. What causes microcytosis? Well, any pathologic state that decreases the production of the intracytoplasmic contents for the red cells will cause the red cells to be smaller. The bone marrow is making plenty of red cells. It just doesn't have enough stuff to package into the red cells. Hence, the red cells become microcytic. We see that in the setting of iron deficiency, where we need iron to produce hemoglobin. If we do not have enough iron, we cannot produce the hemoglobin. Therefore, we do not have enough hemoglobin to put into the red cells, and each red cell becomes smaller. Another cause would be natural globin deficiency, such as a thalassemia. We're not able to make enough hemoglobin A1 and therefore we have less hemoglobin to put into the red cell, and each red cell is smaller. We do see a decreased production of heme in congenital sideroblastic anemias and in lead poisoning. That too would cause microcytosis. And finally, 10 to 20% of anemias of chronic disease will be mildly microcytic, related to poor iron transport into the erythron, causing a decreased production of hemoglobin. And that's it. If you have a low retic count and you have a microcytic state, you have one of 4 diseases: iron deficiency, thalassemia, congenital sideroblastic anemia or lead poisoning, or anemia of chronic disease. Where do we see iron deficiency? It's the most common cause of microcytic anemia in the country, often distinguished on history, related to chronic blood loss, can be nutritional, but in the United States, if it's a nutritional iron deficiency, it's almost always related to an increased iron demands as well, such as what we see in teen pregnancy or lactation. We do see iron deficiency from chronic malabsorption, such as in bariatric surgery or celiac disease. When we see somebody with iron deficient, we need to be aware they're 31 times the risk of malignancy in the next 2 years. And up to 12% of people at the time of their iron deficiency have a malignant tumor. Symptoms you're all well aware of include pica and pegaphasia, chewing ice, spooning of the nails, glossitis, a red sore tongue, an esophageal web, difficulty swallowing, alopecia, restless leg syndrome, one people don't know much about, and beechuria, or the presence of red urine when you eat beets. Whenever somebody has iron deficiency, of course, the source of that blood loss needs to be evaluated, and iron replacement needs to be undertaken. Oral iron replacement is always preferred. It's safe and effective. In those patients who cannot tolerate oral iron replacement and/or cannot absorb it, IV is okay. When we start to replace with iron, we should begin to see a reticulocytosis in 7 to 10 days and a rise in the hemoglobin in 3 weeks. If we do not see that, be concerned that either the patient's not taking the iron or they're not absorbing it. Thalassemia is a microcytosis with normal iron stores. It comes in 2 varieties, alpha and beta. They need to be recognized because often thalassemias are treated with iron under the presumption that they're iron deficiency anemias. Be careful because the thalassemic state does cause hyperabsorption of iron, and you can easily iron overload a patient with chronic iron replacement for what is not an iron deficiency anemia. If you're going to try to diagnose alpha thalassemia, be sure to get genetic counseling, as that can have significant impacts on the health of the child, and document the diagnosis, of course, to avoid iron overload. Anemia of chronic disease. What is a chronic disease? Well, chronic disease can be infectious, inflammatory, neoplastic, trauma, diabetes, elderly patients, or acute on chronic immune deficiencies. What causes anemia of chronic disease? A blunted erythropoietin production in the kidney because of the inflammation. Blunted erythropoietin effect on erythropoiesis, again because of the inflammation. Shortened red blood cell survival, again because of the inflammation. And altered iron metabolism leading to a functional iron deficiency, those patients that have microcytosis. What mediates it? The cytokines IL-1, IL-6, and TNF-beta. That causes apoptosis, decreased erythropoietin expression, decreased erythropoietin receptors, and stimulates decreased iron absorption. When we do a bone marrow in somebody with anemia of chronic disease, we often will see increased amounts of iron storage in the macrophages, but that iron paradoxically does not get into hemoglobin. Okay, so that's microcytosis. What about macrocytosis? Well, it's kind of the opposite. In the setting of a macrocytosis, we're able to make plenty of hemoglobin, typically, but we're not able to make enough red cells to put the hemoglobin into. Therefore, each red cell is bigger than it would otherwise be. These are characterized by interference with DNA synthesis. We know of it as occurring in people with B12 deficiency, folic acid deficiency. Drugs such as our anti-neoplastics in cancer care, anti-epileptics, tyrosine kinase inhibitors. We see it as a side effect of chronic alcohol ingestion, chronic liver disease, although that's related more to a membrane disorder, hypothyroidism, and myelodysplasia. And that's it. So if you have somebody who has a low retic count and a macrocytosis, this is your differential diagnosis. Well, what about the third category, normocytic? Much more difficult. A lot of our anemias follow into the normocytic category. What are the causes of those? Number 1 and number 2 are erythropoietin deficiency and anemia of chronic disease. Always suspect erythropoietin deficiencies, sometimes even in somebody with a normal creatinine if they have a small body habitus or an older population. You can check erythropoietin levels now very easily, and in somebody who's significantly anemic, they should be elevated. If they are not, they have erythropoietin deficiency. Anemia of chronic disease, 80 to 90% of the time is normocytic. It's a clinical diagnosis based on the state of the patient, and on iron studies should have a low iron and a low TIBC because of its effect on hepcidin. We can see endocrine dysfunction causing normocytic anemias. We can, of course, see true bone marrow disease in the way of aplastic anemia, pure red cell aplasia, or other causes of bone marrow failure such as leukemic infiltration, myelomatous infiltration, granulomatous disease. All of these would present with a leuko-erythroblastic picture, meaning a significant immaturity in the peripheral blood. So we have anemia and we do a retic count. We do that so that we don't have to worry about half the differential diagnosis. If the retic count is high, it's an anemia of shortened survival, it's not iron deficiency, and we look at our causes. If the retic count is low, then it's an anemia of decreased production, and we look, is it microcytic, is it normocytic, or is macrocytic? I personally have found this chart to be incredibly helpful in differentiating out the anemias, and I hope you find that it is as well. Now, on to thrombocytopenia. Unfortunately, thrombocytopenia does not lend itself to an easy algorithm for evaluation of the disease. What we will attempt to do today in the next 20 minutes is define what thrombocytopenia is, discuss briefly the physiology of that platelet production, discuss the various causes of thrombocytopenia, and then try to elucidate an approach to the evaluation of these thrombocytopenias that makes sense in clinical practice. So what is the definition of thrombocytopenia? Everybody here knows that it's a platelet count below 150,000 per microliter. Now, interestingly, because of how we define normal, that means 2.5% of the population will normally be abnormal, will normally be below 150,000. Interestingly, studies have shown that there is some seasonal variation from patient to patient in their platelet counts. Platelet counts fall a little bit in the fall and the winter months. They go back up in the spring and summer. Nobody knows why that is. Well, there's a wide range of normal platelet counts between people, anywhere from 150 to 450,000. In any given person, it tends to be relatively stable. Meaning if somebody is 350 one month, they'll probably be in the mid-300s for years to come. Likewise, if somebody's normal is 150, they'll stay in the low end of normal for the majority of their life. When you are presented with somebody with thrombocytopenia on a CBC, beware of pseudo-thrombocytopenia. What is pseudo-thrombocytopenia? As the name would intend, it's not true thrombocytopenia. It's an error in the way the machine was detecting the platelets. The most common cause of this error is platelet clumping. Platelet clumping is related to the anticoagulant used when the blood is collected. That anticoagulant causes agglutinins to be exposed and causes platelets to clump before the measure occurs. Therefore, the machine is measuring 2 and 3 platelets clumped together as 1. This is most common with EDTA, but it can sometimes occur with citrate as well. We can also see clumping in a blood specimen if there was insufficient coagulant used in the collection. There are some diseases that cause giant platelets, especially myelodysplastic syndromes, in which case those giant platelets may be misread as red blood cells by the Coulter counter, indicating a thrombocytopenia that doesn't really exist. And sometimes we'll see benign clumping secondary to drugs such as abciximab, which is a 2B3A inhibitor. How do we define the degrees of thrombocytopenia? Well, it's relatively simple. Mild thrombocytopenia being 100 to 150, moderate being 50 to 100, and severe less than 50. That's nice, but what we're interested in knowing is what's the bleeding risk of the patient with these platelets. Well, it's important to know that even though the normal is 150, surgery is pretty much safe in anybody over 50,000 platelets. If you have high-risk surgery, such as neurosurgery, perhaps the surgeon would like a platelet count of greater than 100,000, but 50,000 for most procedures. When do we see risk for spontaneous bleeding? Usually not until the platelet count is less than 10,000. There are, however, some thrombocytopenias that are associated with thrombopathy, such as in Bernard-Soulier syndrome. That's a genetic disorder in which you don't make enough platelets, and those platelets that are made are defective. And therefore, even with relatively mild forms of thrombocytopenia, there's a lot of bleeding in those diseases. If the thrombocytopenia is related to primary bone marrow dysfunction, meaning that the bone marrow is not making enough platelets, a platelet count of 50,000 in that setting may be at more risk for bleeding than a platelet count of 50,000 due to shortened survival. The reason being is in a thrombocytopenia related to shortened survival, every single platelet in the peripheral blood is relatively fresh and has fresh granules and works well. In the setting of an anemia related to bone marrow dysfunction, or thrombocytopenia related to bone marrow dysfunction, such as an acute leukemia, those platelets that we're reading on the Coulter counter may be 5, 7, 10 days old and not quite as functional as the fresh platelet associated with ITP. So what is the physiology of platelet production? Well, platelets are produced in the bone marrow, just like red cells are, except they're produced from budding off of megakaryocytes. The number of megakaryocytes in the bone marrow adjusts with demand. Each megakaryocyte in its lifetime is capable of producing somewhere between 1,000 and 3,000 platelets. And we make, on average, 35 to 50,000 new platelets per microliter per day. The normal lifespan of those platelets is anywhere from 8 to 10 days, although this can be significantly shortened in diseases such as autoimmune thrombocytopenia. At steady state, fully 30% of our platelet mass is sequestered in the spleen. The production of these platelets is controlled by thrombopoietin, the sister to erythropoietin in red blood cells. Contrary to erythropoietin, thrombopoietin is not made in the kidney, it's made in the liver. And contrary to erythropoietin, the level of thrombopoietin production in the liver is at a constant rate. It does not go up and down. Then how does thrombopoietin maintain a normal platelet count? Well, that steady state of thrombopoietin that's made in the liver is absorbed by the membranes of circulating platelets, thus reducing the level of thrombopoietin when there's a lot of platelets circulating. However, when there are not many platelets circulating, then not much thrombopoietin gets absorbed into the membrane of those platelets, and there's more thrombopoietin to stimulate production of megakaryocytes. So what does that remaining thrombopoietin do? It promotes growth of megakaryocyte colony-forming units, which produces more megakaryocytes. It drives the endomitosis of those megakaryocytes, meaning it causes them to bud more frequently. It inhibits the programmed cell death of the megakaryocyte, allowing it to last longer. And it drives maturation of the megakaryocyte so that it more rapidly produces the platelets that are needed. The production of platelets can increase at least 8-fold in the presence of thrombopoietin. So we think about thrombocytopenia as something that causes a risk of bleeding. But it's important for the clinician to remember that there are some thrombocytopenias that are actually associated with potentially life-threatening clotting risks. The one most of us are aware of is heparin-induced thrombocytopenia. In the setting of heparin and thrombocytopenia, the platelets are activated and often will cause clot, especially around foreign bodies within the bloodstream, such as catheters, or in the postoperative state. It is caused by heparin-induced autoantibodies against PF4 that stimulate the platelet activation. TTP, or thrombotic, thrombocytopenic purpura, is also a thrombocytopenic state in which the platelets are activated and actually cause more clotting rather than less clotting. The platelet aggregation is caused by an absence of, or antibodies to, ADAMS13, which breaks down large or very large or ultra-large von Willebrand factor into smaller units. Other causes of thrombocytopenia that are associated with clotting include DIC, antiphospholipid antibody syndrome, and PNH, as we mentioned above. So what are the causes of thrombocytopenia? Well, very much like red blood cells, there is a problem with impaired production, a primary bone marrow disorder. Other causes of thrombocytopenia, however, include consumption in thrombi, such as DIC, and we'll talk about that, peripheral destruction, such as autoimmune, dilution, and sequestration. So by definition, impaired production out of the bone marrow is almost always associated with pancytopenia. The bone marrow is responsible for making not only platelets, but red cells and white cells, as well as dendritic cells. Those things that affect production of platelets out of the bone marrow almost universally affect the production of other cells out of the bone marrow as well. Examples of what could do that would be nutritional deficiencies, famously B12 folate, myelodysplastic syndromes where we have abnormal stem cells that can't mature, malignancy, disrupting bone marrow architecture and replacing the bone marrow, lipid storage diseases doing the same thing, alcohol, which is a bone marrow suppressant, and infection or granulomatous disease, which also suppresses bone marrow function. Rarely we'll see a drug effect rarely we'll see a drug which will induce loss of just megakaryocytes without anything else in the bone marrow. That has been reported. In my 25-year clinical practice, I've never seen a case of that. So, what can cause platelet consumption? Well, we talked about DIC. What is DIC? It is a coagulopathy leading to consumption of platelets into fibrin clots. These microthrombi cause schistocytes as red blood cells try to get past those microthrombi, and the consumption of the clotting factors causes an elevation of the PT and the PTT. DIC is almost always associated with a significant systemic illness, and the treatment for DIC is actually to treat the underlying illness. So DIC is a coagulopathy where platelets are absorbed into clots caused by activation of the clotting system. Contrary to that, TTP is a platelet microthrombi disease. The platelets themselves are activated by the loss of Adams 13. These form almost exclusively platelet clots without activating the coagulation system. Hence, the drop in platelets and the schistocytes that we see in TTP is almost always associated with normal clotting tests, PT and PTT. It is important to differentiate TTP, or HUS, from DIC and from the other causes of thrombocytopenia. TTP is 90% fatal when it goes without diagnosis. TTP is 80 to 90% curable when the diagnosis is made. The clinician needs to be acutely aware of a thrombocytopenia that occurs in the setting of an anemia and schistocytes, and needs to be aware that that is TTP until proven otherwise. Another cause of thrombocytopenia is peripheral destruction, or shortened platelet survival. As we mentioned above, the typical lifespan of a platelet is 8 to 10 days, after which it is naturally removed by the reticular endothelial system. This clearance, however, can be greatly enhanced due to antibody-mediated opsonization, meaning the platelet is coated with antibodies, typically IgG, and when that platelet circulates through the spleen or past other macrophages, it is removed from the system, thus shortening the platelet survival. This is most commonly seen secondary to primary autoantibodies against ITP. We can see primary autoantibodies not only against ITP but also against red cells, in which we have a combined immune thrombocytopenia and an immune hemolysis. That's called Evans syndrome. We do, however, see immune destruction of the platelets secondary to other immune diseases, such as lupus or rheumatoid arthritis. And we also see it secondary to lymphoproliferative disorders, where the immune system is disrupted by the malignant clone of B cells or T cells, such as in CLL. Finally, we can see antibodies against antigens on the surface of platelets caused by the exposure to drugs, famously quinine in the setting of quinine purpura, and in the setting of antibiotics, famously penicillin, but many others. We can see dilution of the platelets. This is usually quite evident to the clinician. It has to do with massive fluid resuscitation. And there's a body of literature in the trauma literature that states that when massive dilution occurs, we should be replacing 1-to-1-to-1 ratio of red blood cell units with platelets with FFP. Finally, redistribution, most commonly caused or almost exclusively caused by splenomegaly, is a very common cause of thrombocytopenia. As we stated before, nearly 30% of platelets are typically sequestered in the spleen at steady state. Hence, the rise in the platelet count that we see with the advent of splenectomy in many of our patients. In the setting of an abnormally enlarged spleen, however, anywhere from 60 to 90% of the platelet mass may be sequestered in the spleen. Now, those platelets aren't absent, they're just being sequestered in the spleen. And so even with severe thrombocytopenias of less than 50,000, we very rarely see bleeding in these patients with thrombocytopenia because they do have adequate platelet reserve packed away within the spleen. In studies looking at the causes of hypersplenism and thrombocytopenia related to chronic liver disease, the most common cause across the United States is NASH, non-alcoholic steatohepatitis. Second most common being alcohol, and the third most common being hepatitis C. So how do we approach thrombocytopenia? Unfortunately, we don't have a neat test like the retic count to guide our differential diagnosis to one side of a graph or another. So the first thing we should do is be sure we're dealing with thrombocytopenia. Repeat the blood count. Now, in patients whose platelet count is markedly low and at risk for bleeding, that repeat should occur immediately before the patient has a life-threatening bleed into the brain. However, in many cases, it's only a mild thrombocytopenia, 100, 110, 120,000. Those patients are often found asymptomatically as an outpatient, and the repeat does not need to be immediate, but can wait 2, 3, 4 weeks before that's confirmed. Once it has been confirmed that the patient does have a thrombocytopenia, review the blood film. This rules out pseudo-thrombocytopenia related to clumping and giant platelets, but it also looks for important clues as to the etiology. If one has a thrombocytopenia and sheath schistocytes, as we said before, that's TTP until proven otherwise. If there are nucleated red blood cells, which are always pathologic in the peripheral blood, or if we see a left shift of the other white cells, such as a leukoerythroblastic picture, that would be most indicative of a space-occupying lesion within the bone marrow, such as malignancy or granulomatous disease. If we see spherocytes, we think of autoimmune disease, perhaps Evans syndrome, perhaps sequestration of the platelets in a large spleen caused by hereditary spherocytosis. And if we see signs of dysplastic red cells, think of a stem cell disorder such as myelodysplasia. So one of the first things that folks recommend in trying to differentiate the causes of thrombocytopenia is to ask the question, is this thrombocytopenia acute or chronic? Obviously, that entails a history and review of previous CBCs. If many previous CBCs are seen and the platelet count has always been slightly low, that's obviously not nearly as urgent an issue as something that is acutely low. An acute drop in platelets may indicate a rapidly evolving scenario. Even if the platelet's only 60,000, if it was 150 the previous week, that's a significant drop, and it could be 20,000 by next week. Secondarily, determine if the thrombocytopenia is isolated or is associated with other hematologic or medical abnormalities. In isolated thrombocytopenia, without an anemia or a leukopenia or other systemic disease, is rarely a medical emergency, unless, of course, it's severe thrombocytopenia, platelet counts of 20,000 and below. Combined cytopenias, thrombocytopenias associated with also an anemia, which may be TTP or DIC, or associated with anemia and a leukopenia, often are secondary to more serious diseases of the bone marrow, and if they're severe, demand a rapid response and hospitalization. As I stated before, if we see schistocytes, think TTP and DIC. And associated with thrombosis, think the above two, but also think HIT, especially in the hospitalized patient. So if a thrombocytopenia is both chronic and isolated, statistically, it is most likely to be ITP. When faced with this in the clinic, you need to make sure it's not related to chronic hepatitis C infection, which can cause a chronic mild thrombocytopenia. We need to make sure it's not associated with HIV infection, which can present with an immune thrombocytopenia, or whether it's secondary to another immune disorder. If those have been ruled out and the patient is stable and it's an isolated thrombocytopenia, then it is most likely ITP. The American Society of Hematology does not recommend a bone marrow biopsy to evaluate that further, as there are very few other things that can cause that. If that ITP is not severe, 100,000, 120,000, it can be safely watched with periodic CBCs, educating the patient to watch for things like petechiae or purpura, which might indicate worsening thrombocytopenia. If it is a chronic thrombocytopenia that is associated with other hematologic abnormalities, then it's likely not to be ITP, but actually some primary bone marrow dysfunction. Most commonly in the elderly, myelodysplasia. There may be indolent malignancy in the bone marrow, such as a low-grade lymphoma. It may be related to sequestration in what was heretofore unrecognized chronic liver disease and splenomegaly. It may be secondary to nutritional disorders. And finally, it can be associated with rheumatologic disorders, most famously things like Felty syndrome. What about acute and isolated? The acute presentation of ITP. Once again, acute drop in the platelet counts without a drop in the red cells, without a drop in the platelet or in the white cells, is almost always immune mediated. The severity of the drop will dictate the therapy. A very mild drop can be watched. A severe drop needs to be treated. A drop associated with mucosal purpura needs to be treated immediately. Outside of ITP, though, we need to be aware of other things that can cause an isolated thrombocytopenia, such as an untoward drug reaction. Once again, we talk about quinine purpura. Quinine famously can drop the platelets very rapidly after just one cocktail in a patient who has been previously exposed to quinine. One should always evaluate new drugs. Typically, in a patient that's not been exposed to a drug, within 10 to 14 days, that new drug can cause a thrombocytopenia. This is usually self-limited. When the drug is stopped, the patient recovers, and it rarely leads to clinical bleeding. Finally, when we see an acute and isolated drop in platelets in the setting of heparin, heparin-induced thrombocytopenia is a big worry, and in the right clinical setting, clearly needs to be ruled out, and all heparin, including heparin flushes, heparin line catheters, so on, need to be removed from that patient. What about acute thrombocytopenia associated with other hematologic abnormalities? Now we're talking about typically our hospitalized patient. Again, always think microangiopathic hemolytic anemia. The first thing besides determining that the platelet count is low is to look at that blood film and be sure there are no schistocytes. Outside of the microangiopathic hemolytic anemias, look for other cytopenias that might be indicative of marrow suppression. We see alcohol. We see infection and sepsis. Sepsis causes a suppression of bone marrow function. We see viral infestations. We see malignancy, cytotoxic drugs used to treat cancer, nutritional deficiencies, and of course, massive transfusion. What is most common in the ICU setting? That's when a lot of us get consulted to see patients with thrombocytopenia. Well, in one study, the most common cause by far was infection, sepsis, DIC. 23% of the time, or 48% of the time it was sepsis, 23% of the time an infection was actually isolated, 18% of the time they actually did have documented DIC. But the combination of those three is by far the most common cause. Statistically, the second most common cause after that is liver disease, either known or newly diagnosed. The third would be drug, 9% cytotoxic drugs, 9% non-cytotoxic drugs, such as heparin and other antibiotics. Occasionally, 6 to 7% of the time, we will see a primary hematologic disorder. We can see it as secondary to massive transfusion, of course. And finally, alcoholism can cause a thrombocytopenia associated with other cytopenias. In summary, a platelet count less than 150,000 defines thrombocytopenia, but that does not always define bleeding risk. The bleeding risk is highly variable depending upon the severity of thrombocytopenia and the cause of the thrombocytopenia. Thrombopoietin is the driving force in platelet production. The etiology of thrombocytopenia can be separated into 5 broad categories, but unfortunately, oftentimes a combination of these exist in any given patient. That includes primary bone marrow dysfunction, consumption in thrombi, peripheral destruction, such as ITP, dilution, such as with transfusion therapy, and sequestration, such as with splenomegaly. The evaluation of thrombocytopenia demands a review of the blood film. There's no replacement for looking for the schistocytes or looking for dysplasia or looking for a leukoerythroblastic picture. It can save lots of money in testing and drive one quickly to the right diagnosis. It's helpful to determine the chronicity of the thrombocytopenia. Is this brand new? Or is this an old finding that needs to be evaluated but not on an urgent basis? And you need to review the medical history. What are the concurrent medical diseases? Is the patient septic? Has the patient heparin, etc.? Finally, the timeliness of this evaluation is, of course, dependent upon the bleeding risk and the acuity of change. A rapid drop from 300 to 60, even though the bleeding risk may not be high today, would certainly be an indication for a rapid evaluation of that thrombocytopenia. A chronic thrombocytopenia of 80,000 present a year ago, 2 years ago, and today does not beg for the same type of evaluation. Office evaluation is often appropriate for asymptomatic patients with mild to moderate thrombocytopenia. Urgent evaluation often in a hospital-based setting for folks at an increased risk for bleeding or for a rapid demise in the platelet count. While we may see a lot of, we may feel like we're in a pretty deep hole when we're trying to figure out how to evaluate both anemia and thrombocytopenia, with the right tools, mostly knowledge and some simple blood tests, we're often able to climb our way out.